Good afternoon, everyone. My name is Shelagh Fraser, and I am the moderator of today's panel. I'm also the Chief Medical Officer of LifeOmic and a practicing internal medicine physician in Indianapolis. Today, I'm joined by some truly remarkable panelists from across the country to talk about this concept of health literacy, which frankly, I think is more important than ever, not just for individuals, but for organizations who are communicating really important and sometimes difficult health information every single day. I am particularly curious about the conversation today. At LifeOmic, our team of science writers, illustrators, and program builders are really committed to promoting health literacy in all of our educational content. We have, tools that include our SciArt flashcard courses called Lifeology, our really cutting edge precision wellness program for corporate wellness, and our monthly subscription health optimization tool called Life Ascent. And in each of these programs, we have intentionally worked to be quite mindful of health literacy considerations, but there's always more to learn and more to understand. For those of you who are interested in health literacy, which presumably you are if you're here today, I encourage you to take a look at these examples of really excellent work. You can find some additional information about the LifeOmic programs at lifeomic.com/health literacy, and I think that we'll have a link to that in the chat. But let's get on to what promises to be a really terrific discussion. First, a few housekeeping items. We will have some hopefully really good conversation for about 45 minutes or so. And then with time remaining, we'll have 10 to 15 minutes for Q&A. As the conversation progresses, whenever you have questions, please feel free to drop them in the Q&A box, and we'll circle to those at the end. Before we dive into the conversation, though, I'd like to get started with some introductions. So let's begin with Terri McGuire. Terri, can you just tell us a little bit about yourself?
Hello, everyone. I am joining from the East Coast, so good afternoon. I am Terri McGuire. I am a practicing physician assistant. I have over a decade of experience in both medicine and public health. I am also the founder and CEO of Evolve Health and Wellness Community, where we focus on enhancing and improving health literacy for both patients as well as organizations. And we do so to improve health outcomes as well as advance health equity. Look forward to the conversation. Thank you so much for having me.
Thank you. Next, we'll go on to DiAn Augustus.
Hey, y'all, can you still hear me okay? My microphone shut off for a moment. All right, I am DiAn, also known as Deviation on the web. I am an artist, and the educational resources that I provide are actually mostly in adults' holistic sexual wellness. I use graphics and design as a way to simplify hard topics in communication.
Thank you. Moving on, Michelle Paul.
Hi, so I'm Michelle Paul. I'm located over in the East Coast, close to it anyway, in Utah. I am a registered nurse and a technical writer, so I specialize at LifeOmic in health writing and content management, particularly right now on the Life Ascent program that Shelagh briefly mentioned. And we're wrapping up content production on that one in the next few months, and then we'll be moving on to some other Lifeology courses specializing in various health issues that local county, like health departments and counties, are very interested in. So I'm looking forward to doing that.
Excellent, thank you. And finally, we have Russ Bennett.
Hi there. Like Shelagh said, my name is Russ Bennett. I'm a consultant to the Institute for Healthcare Advancement, as well as for several other organizations on health literacy, social determinants of health, strategy, and marketing. I've been in healthcare for over 30 years, worked in the hospital, the insurance, the nonprofit, and the government space. About 22 years ago, I was the founding executive director of the U.S.-Mexico Border Health Commission, and which was good because I had grown up in Mexico and I speak Spanish. Right now, for the last year, I've been a member of PCORI's Patient Engagement Advisory Panel. So very interested in engaging patients and using health literacy to do that.
Sorry, I almost forgot to unmute myself. Wonderful. Thank you all for joining us today. So as we get into this conversation, I thought it would be helpful to start off by kind of setting a baseline for people who may be new to this concept of health literacy. So I'll start with you, Michelle. What do you think it looks like for individuals to have health literacy, and what kind of improved outcomes can result when individuals or communities achieve a specific threshold or level of health literacy?
Okay, yeah, thanks, Shelagh. So this is a pretty broad question. I'll try and summarize it as briefly as I can. So with health literacy, I like to break it down into talking just about what literacy is. Usually when we think about literacy, we think about it as, oh, it's just these hard skills of being able to read and write. And it includes the ability to read and write, but it also includes a lot of soft skills that we don't really think about. In order to read and write, we also have to be able to think about words and how to form them into sentences, how to get across certain points and opinions, how to read and absorb information and be able to form thoughts and opinions from that. So not only is it just the hard skills of reading and writing and using words, but it's also being able to critically think, being able to know where and how to access things to read that we'd be interested in, how to share that information, how to use words to share our opinions. So there's a lot that kind of goes into it besides just using words. I use my hands a lot to talk, so that'll be fun. So health literacy then is not just knowing what like healthcare is, what diseases are, what symptoms are, what treatments are. It's basically knowing how to know when you need to go and get that information, how to access that information, how to use it, and then how to assess it. So health literacy is knowing, okay, well, I know kind of what prediabetes is. How do I treat that? Do I go to a doctor? Are there resources online that I can look at? Are there books I can read? Are there skills that I've already learned because of the demographic I grew up in, where I know that exercise is important, that certain foods are probably going to be increase my risk for certain diseases as opposed to others. And then once we get to that point where we're talking with doctors, it's knowing, okay, well, just because one doctor said something doesn't mean that it's the truth, that maybe I need to get a second opinion, or maybe I need to listen to my body more. And a lot of demographics that perhaps grew up in poverty or in different cultures where they have different values or different understandings of health, they might not know that they might just, especially I've seen it a lot in rural countries or rural counties where they don't really interact very often with doctors, or they only have the one doctor. They haven't had the experience of advocating for themselves, of knowing how to access these health resources that we have. So when a community, kind of answering the second part of this question, when individuals or communities have health literacy, they know how to access these health resources and how to advocate for their health. And they understand when that is, how to do that. And when you understand how to do that, you're able to engage in preventative health, as opposed to just waiting for when something is absolutely broken and you need to now go figure out how to do that. So yeah, there's a lot to talk about with health literacy. I've also worked in other countries, and I've seen how other countries have done their health, and I've had people tell me very interesting things about how they believe health works. And that's just learning and trying to teach people how to live healthier lives when perhaps they grew up somewhere where you don't really have access to that.
Yeah, you bring up a lot of great points. And then we'll circle back around, I think, to some things related to the cultural components you're talking about. But I wanted to jump a little bit into kind of that distinction between individual and community, and talk a little bit more about factors that specifically can influence an individual's health literacy. So Terri, maybe we can move on with you. Do you think there are elements both within and outside of someone's control that can impact their ability to improve or access the kind of accurate information that Michelle was referencing?
Let me make sure I come off mute as well. So yes, absolutely. So I think in conjunction to what Michelle was also saying, context really, really matters. And so understanding that how someone presents, there are so many layers. It's almost like an onion. You have to pull so many different layers back. So cultural influences, is certainly a big factor. And there's so many different things that are both in and outside of someone's control when navigating the healthcare system. So when thinking about things that are outside of control, there are a number of factors. So of course, people can't control what an insurance company is going to pay for, how expensive drugs are going to be, and then also the ideas and the attitudes that medical professionals may have, any other staff. And so, thinking about things like racial bias, medical racism is a big deal, thinking about how our medical system, the history of it. And then also, there's so many different other factors. We're thinking about people who are gender diverse and people who have disabilities, and how medical gatekeeping may sometimes show up, and thinking about who is privy to certain information, who is offered screenings. And so, we certainly see how these types of things, or the lack thereof, can certainly impact health outcomes and disproportionately impact certain groups. When I'm working with clients, I do certainly talk to them about things that can be within their control. So some things such as, taking notes during a medical appointment. Our healthcare system is very complex. There's a lot that is discussed, and, chronic disease is a big deal within our healthcare system, but the management of it does not just happen within a healthcare setting. The majority of it happens outside of that setting. So being able to feel empowered to ask questions in that appointment, but then also taking notes to go home later to be supported by someone that can assist you with going over some of the topics that were discussed. Also being mindful of, who you're seeing as a healthcare provider. So looking at reviews online. And if you do find a healthcare provider that is not meeting your needs, that is not using culturally competent language with you, certainly feeling empowered to change your healthcare professional until you can find someone that is going to meet those needs for you. Also being mindful of where you're obtaining your information. So misinformation is rampant. It is a big deal. And so I certainly like to make sure that patients are aware of where they are obtaining their health information. So those are some factors that are both within and outside of control that can impact health literacy.
Thank you. DiAn, I think maybe this may be an area that you have some thoughts as well. Anything to add to what has been mentioned?
Just a little bit. I mean, Terri, you hit the nail on the head. And one other thing that I think is definitely out of people's control that I hear every once in a while when people are talking about health disparities and social determinants of health is you can't always control which medical facilities and systems you are a part of. If there are not outreach programs, I grew up in an area where a lot of people speak Gullah or Geechee, and it's not recognized as an official language in the US. And it isn't quite a Creole, it's a whole language with its own dialects. I think Russell mentioned speaking Spanish. There are areas where if the medical facilities are not providing information to you in a language you can comprehend, and even if you've learned standard American English as well, it's still gonna change things just as little as Terri was talking about, knowing that you can change your medical professional. I didn't grow up with that knowledge. The way I grew up, you don't question authority, really. A doctor is somebody who is in authority, and that's just kind of a cultural thing. If they say, do this, and they gave you not necessarily bad information, but maybe information that doesn't work with your lifestyle, that you can't keep up with in your culture because of the things you do or the way that you live, then I didn't know that I could just go get a doctor who understands my community better. I had no idea, nor would I have known where to look that up until I was pretty old. I was much older when I learned that. And that's something that is outside of control, as well as certain things that are within our control. Like how do we meld our ancestral knowledge, herbal medicines and things like that, that some of us will feel comfortable using if the medical facilities in our area are not willing to even consider the possibility that any of them are valid or healthy or important. So now, you're hitting up auntie and grandma hoping that they're giving you good information because the doctor won't say, oh, okay, yeah, I've heard of that plant. Give it a try, but go ahead and try Tylenol if that doesn't work. Those things, there's not too much you can do, but sometimes we are disempowered to do what we can do if we don't have that other part of community engagement on the behalf of our healthcare professionals and providers.
They're excellent points. I think about even historically within the United States, the idea of your family doctor, right? The doctor who's taking care of your whole family, and even maybe stepping outside of that relationship is challenging. If your parents and siblings all go to the same doctor and you feel like it isn't a good fit, to feel empowered to make those changes. Well, so this idea of cultural competency keeps coming up, right? I mean, I think that's obviously a huge element here, and it sounds so important to me when thinking about health literacy. Russ, this seems like an area that would be of great interest to you, and so I'm curious how you think that how an individual and organization can share meaningful information when they're speaking to a diverse group. How do you start from the healthcare side, start getting the right kind of information out there when you're speaking to diverse populations?
Well, that's a great question, because in my experience, what I've learned is, first of all, you need to know your audience. Who are you actually speaking to? But beyond that, you need to respect your audience. So it's not just knowing them, but having an understanding and a respect for them. Is your audience gender diverse? Are they language diverse? Are they limited English proficiency? Are they racially or ethnically diverse? When you're addressing them, as DiAn was saying, if you're working in a certain community, you need to know enough about that audience as to what kinds of myths they deal with in their life, what kinds of diseases they have. For example, if you're dealing with a high Hispanic audience, or an Asian Pacific or Native American audience that may have a high possibility of having diabetes, then that's one of the things to take into account as you're speaking about it. I found an interesting article in medpro.com by a professional named Laura Casella, and she talks about strategies for addressing health literacy that often target patient comprehension. And they involve speaking clearly, avoiding jargon, using words that patients understand, reducing redundancy and ambiguity, and so forth. And these strategies are crucial. But another critical element of effective communication is cultural competence. And often we do all of those things and we don't think of the cultural competence. And cultural competence and health literacy might be viewed as separate issues, but a patient's beliefs, values, and experiences significantly shape how the patient perceives and understands health information.
What are ways that you think providers are best able to develop some core cultural competency in their practice? I mean, I'm thinking just frankly, as a physician, the kind of education that physicians get, which is different now than probably when I was in medical school, but is, what kind of training is most useful, or perhaps more importantly, how can physicians and other kinds of healthcare providers maintain that level of competency over time?
Well, it's interesting. When we look, say, at the Hispanic population again, there's 60 million Hispanics in the US, and maybe, more than half of them, their language of preference is Spanish. And this is interesting, by the way. They may speak English very well at work. They get along fine, but when they have to deal with a complex or maybe a more personal subject, they revert to their mother tongue. Very often, the words that they use are the words that their grandmother or their mother taught them. I don't know, tummy instead of stomach or whatever, and the equivalent in other languages. So one of the things I've seen, even if 18-19% of the population is Hispanic, there's only about 5% of the physicians in the US that are Hispanic. So there are many physicians of other ethnicities that are dealing with the Hispanic community. And for example, here in California, you'll find many Asian physicians, Koreans, Chinese physicians that they're very aware that they have to do something a little bit different for their Hispanic population. And so they hire, excuse me, Hispanic or Spanish speaking office staff. So that supplements what they as a diverse physician know that they need to have some special communication techniques with diverse audiences, but they may not know what communication techniques or what language they need to use with their patients. So they supplement their office by adding staff. The easy thing would say, oh, go out and hire a Hispanic physician. Well, there aren't enough of them, and we need to increase the pipeline. So you do what you can, and you get awesome nurse advocates or caseworkers, or even promotoras, which is the community health worker, and those really help to address the patient. And I notice a point here that somebody's talking about numeracy. So I know, Shelagh, that you'll pick up on that in just a minute, because numeracy is a very important part of health literacy.
No, I agree. And actually, there's a question, and I know the plan was to answer all questions at the end, but this question actually, I think, is quite pertinent to what we're talking about right now. And some of you may have some thoughts on this. Someone asks, how do you educate a provider who thinks that they don't need health literacy in their organization, and what they say goes? And then the questioner has a specific question about that. If in this case, a physician doesn't like it if the patient is questioning COVID vaccination, right? And that they aren't open to that discussion. So DiAn, you look like you had a facial response to that. I'm curious how you would talk to individual patients who are experiencing that, and kind of offering them support, and how they can feel empowered in those circumstances.
So one service that I've offered in the past is actually consulting services for healthcare providers on behalf of community. Because what happens every once in a while is there's either community knowledge, or there's a cognitive concept of embodied language. I think Russell was talking about this in a sense, that in our heads, we are speaking the first language we learned. So language is simply us trying to grunt and groan our conceptual somatic expressions into language so that other people can understand us, right? And what happens there is sometimes people don't even understand that they're being, for instance, asked a question, or your healthcare provider and you communicate in such a different way that it comes across as a patient who does not listen. And so what I've had to do is kind of act as a community bridge. So I'm in this community, I'm talking to the healthcare provider. My background is in psychology, and because of that, yeah, okay, I can speak the language. I know some of the jargon. I've had healthcare professionals not realize they were using jargon when they were, because a word in common usage may just be so different from the way it's used in academia or in the medical world. And so definitely having people from the community you're trying to communicate with be able to actually then have these roundtables or panels or something with the healthcare providers to say, hey, let's do a critique. I'm an artist. We have to do critique, y'all, where someone just sits with your beloved work and says, here's where you messed up. And that's it. It's not a personal attack, and it has to be taken as, here's how you can serve this community better. And sometimes I find that's really hard to take on for people. Even if, not saying the community is always right, but I think we all have heard the concept the customer is always right, right? So sometimes it takes a little bit of understanding where the community is coming from, and having somebody who can bridge that language gap, that education gap, sometimes that gap to access that exists. Because there really is. There's a health gap in the way that we all express ourselves and communicate. So I think that's an important one, is there has to be someone finding more people and healthcare providers reaching out and hiring consultants and diversity and inclusion services, and saying like, okay, I do need help. I don't exactly know exactly what I need to do. I've been taught this by yet another person like me, so I need to hear it from the community I'm serving.
Absolutely.
So, one thing that I would add to this, Shelagh, is the physicians can actually use a self-assessment to better understand their own attitudes, beliefs, their values, and their practices. One place where you can go for that is Georgetown University's National Center for Cultural Competence, and we can put that in the chat box in a moment. But to not only do a self-assessment, but to encourage them to participate in education and training about the meaning of culture and how it affects quality of care and healthcare delivery. Also, as I was saying at the beginning, to be aware of health disparities and to be aware of discrimination that affects various populations, as well as common types of implicit and explicit bias that can affect clinical judgment and reasoning. And to be aware of stereotypes. An older person comes into the physician's office, and the older person look like an older person first and a patient next, right?
Mhm.
And you sort of have to flip that. And then, just to weave into all of this is, and DiAn was saying this, the patient and the doctor may be speaking at a different level and a different language. So it's up to the provider to use techniques like teachback, where, and I've taught this so many times, where the group that I'm training, I say, how do you find out if your patient understood what you said? And they say, well, I asked them. And I say, okay, so let's do a little exercise here. They explain something fairly complicated, and then they say, did you understand? And the patient says yes, because they're embarrassed to say no, or maybe they understood it for a moment, but they're going to walk out of there and they're not going to understand it. So really, to train the physicians about using the technique of teachback is, please explain it back to me. I want to make sure I didn't miss anything. Very difficult in some cases to get a physician to adopt a humble posture for a moment, and to not put it on the patient as this patient doesn't understand, but rather, if the patient didn't understand, is it my communication technique?
Mm-hmm. I think that's
Yeah.
Oh, go ahead, Terri.
Yeah, I would also like to add, especially about the humility piece. So there is a lot of ego and resistance to change. And, thinking of healthcare providers and, seeing themselves as, I am the expert, I know everything. But what I encourage healthcare providers to do, healthcare organizations, is to see patients as the expert. Like, we come to you because most of the time we've identified something in our body that does not feel right. And so I am talking to you about what I am experiencing in my body. So I am too an expert. And so there has to be a partnership. And us trying to figure these puzzle pieces out together. I think another piece to your original question is, what do you do as far as addressing cultural competence? So continual medical education is a thing that we have to do to stay, on top of the latest and the greatest. And so also just being mindful of that from a cultural perspective and making sure that there are trainings in place. And so there has to be commitment from healthcare organizations from the top down to ensure that healthcare providers are being trained, and then not only just getting the information, but how are they implementing it into their practice? So most jobs and most professions are going to have some type of performance review at the end of the year. So let's sit down, let's talk about what type of interventions have been made, how are they meeting, the benchmark and the goal. So making sure that we're not just doing training, but we're also assessing how well trainings are working. So those are some things that I would add to that as well.
Mute strikes again. Terri, I mean, that's an interesting approach to thinking about kind of how organizations can work to like implement things to help their providers do better, right? You had alluded earlier, though, to this idea of misinformation or information overload, and that also seems to be another area that can be really problematic, right? You want organizations and providers to be providing good information, but there's a lot of information out there that patients are getting, maybe not from their provider, but just from Google or other locations. Tell me a little bit about what you think about in battling the problem of misinformation, which is a huge topic. So
it really is. And, as I said before, so time is a large barrier in our current healthcare system. And so there's not a lot of time to address everything in a healthcare appointment, especially when you're thinking about there being time for a physical exam and talking about how things have been since we last saw each other, or if this is the first visit. So really, getting a good history. Again, what I try to do is direct people to reputable sources and try to limit those that are not providing true content, because it's rampant, and it's social media is a big thing, and there are some people who are scamming to get money, and they are releasing information and people are grabbing a hold to it. And someone said something really poignant a while back, and it's talking about shifting and transforming our idea of, do patients trust the healthcare system, but more or less, is the healthcare system doing things that are trustworthy? So shifting that onus on the healthcare system and the institutions, because a lot of times that's pushing people to these other venues because they don't trust. And especially now, as we're still navigating COVID-19, a lot of people lost a lot of trust in our public health system with a lot of changing to recommendations. And so it's a really, really big problem, but that's why it's important to have consultants that healthcare organizations can use, or have people within your organization, whether it's nurse navigators, to help to direct patients to good, healthy resources, and really just try to hang on to your population by doing what's best by them.
I think that also, though, circles around to this whole concept of digital health literacy and people's ability to know where to look for information and then how to interpret that information. So Michelle, I'm curious what your thoughts are about that, kind of how a person's ability to use digital sources to access and understand health information ultimately impacts their ability to have any kind of health literacy, and then really take the next step to use that to be engaged in their own health.
Yeah, so digital health literacy is obviously something that's relatively new now that a lot of people have access to smartphones, to the internet, at school, at work, at home. And it ties into organizational health literacy, which is slightly different than like an individual or community's health literacy. The CDC actually defines it as different, and they've updated their definition recently. And I had to pull it up because I don't remember exactly how it was said, but organizational health literacy is the degree to which organizations equitably enable individuals to find, understand, and use information and services. So the key word difference between personal health literacy and organizational health literacy is it's on the organization's responsibility to make sure that these health resources are equitable. So someone who grew up middle class in the city is probably going to be very different than someone who is elderly, who's lived their whole life in a rural community, or in a community that's poverty, like the poverty level, and that's just all they've known. So how, as an organization, can you ensure that this digital literacy, or that health literacy in general, is equitably reached both of these two different types of populations? So digital health literacy is a good way of trying to reach to certain populations, but it can't just be the only way that we reach to like everyone. It can't just be that, oh, well, everyone has access to a smartphone, right? So we can just do everything digital. That isn't true. Not everyone has a smartphone. Honestly, not even every house has a computer or access to the internet, or perhaps their internet is very, very slow. Like my parents live in a very rural community, and this week they're installing fiber cable because they haven't had fiber before. And because they live out basically in the middle of nowhere, we don't really have good internet and it goes down a lot. And so like if I was relying on them to always be on the internet and be able to know how to access things, especially because they are senior, they did not grow up in the digital age. I have to tell my mom multiple times how not to fall for scam emails, how to access her online chart from the healthcare providers. So if you're, as opposed to like a teenager who grew up perhaps with a smartphone and will be able to know, oh yeah, I am very digital literate. I know how to access different accounts. I know what messages are and inboxes and how to do all these things. And they can take that to different platforms as opposed to some other demographics that might not. So digital literacy is kind of like a double-edged sword where, yeah, it's going to solve a lot of problems to access a lot of these resources and services like telehealth. But if you aren't already digital literate, then it's not an equitable way for these populations to be able to access the exact same resources. So unfortunately, it's on the organizations to be able to identify the different demographics that they serve and how it literate in terms of digital literacy or like hard copy literacy each demographic is. In order to make it so that it can close some of these systemic gaps that we have. Otherwise, you're just causing more gaps. And this time it's just going to be the digital literacy gap.
You know, that's a really good point, Michelle. And we shouldn't forget that printed materials can still be very valuable. I saw a couple of comments come through about people being in rural areas where, just as you said, the internet availability is not what we'd like it to be, and eventually it will be. There a lot of people are doing things for that, but meanwhile, having things in written form is very, very valuable. I do a lot of work for rural clinics in Western Arizona. And we developed a booklet, or we had developed it at IHA before, on how to manage your anxiety during the COVID-19 pandemic. And it's welcome. You know, I can give it to anybody that wants, who's on the line. Just let Candace know, and we'll get it sent out to you. But I think what's important is we customized it for this organization, the Regional Center for Border Health, and they gave out a few thousand of them, and then they came back and they said that there is a tremendous request for this because people want to take it and they want to take it home and they want to, you know, leaf through it and write in the book and things like that. So as digital as we get, let's not forget, you know, that there are still many people who would like a book they can hold in their hand.
Yeah, and like what you mentioned, writing notes is like such an important thing for so many people. So it's really hard to do that if it's just like a PDF you download off of your here we use MyChart. It's a system that we use to interact with our providers. So if it's just on your MyChart, it's hard to be like, oh, well, I have a doctor's appointment, I need to remember to do this. Where do I write the notes? And also like write all this complex like healthcare information for my blood test that I don't understand. Whereas if it's just like a printed out form, you can circle it and be like, I don't know what this is, and then take it. And it's just so much easier for them to be able to communicate with their healthcare provider, as opposed to just trying to find it in all these complex dozens of menu items. So absolutely, I still encourage the use of hard copies. Even though it feels for a lot of people like we're moving past that, we should still be pushing to have those available for the people who would like them.
Especially, I think that comes up a lot in people whose care is shared with other caregivers, right? So if being able to show something that's written down sometimes feels like a much more tangible plan to families. or just to individuals. They feel like it's something that they're holding on to. They can reference easily. They don't have to go search for it. But you're right. I think people feel sometimes conflicted about that. That we should be only doing things digitally accessible. So it's a sometimes tricky position. I'm curious, Russ. That's an excellent example of a strategy to kind of promote options for communicating important information. What other kinds of things have you found to be helpful in terms of individual or organizational level, kind of putting into place strategies that are useful for that ongoing sharing of health information?
Well, thank you for the question. You know, one of the things when I go into an organization to try to evaluate whether they are doing anything about health literacy, and if so, if they're doing it well, is to help them evaluate whether their organization supports and advances health literacy. You know, the CDC has picked up a really good document that was written a few years ago by Cindy Brock and others called 10 Attributes of Health Literate Healthcare Organizations, and that's available online. And among those attributes, they sort of bunch them together. Attributes about public health leadership, about the priorities, the training, the access, and the special situations. So one of the things is you want to start at the top and find out if an organization has leadership that makes health literacy integral to its mission, to its structure, and its operations. Because those of us operating down here at the, the level where we deal with the public may really want to do something about health literacy, but if it's not recognized and supported from the very top of the organization and made part of the structure, and the mission, it'll be hard for us to do it. We also want to look if the organization is integrating health literacy into strategic and operational planning, into quality improvement, into goals and measures. And Terri talked about evaluating. So it's not just, doing it, but then evaluating how well it was done. Does the organization have any measures where they're evaluating that? Are they preparing the workforce to address health literacy issues? And again, to Terri's point, are they monitoring progress? And are they providing easy access to information and services and using even clear signage or instructions to help people find their way in facilities and online? Out here in Southern California, there's several hospitals. I would say all the hospitals have a high Hispanic population, but there are several hospitals that have a high Korean population. And so they need to do their signage in the Korean language as well. And, as we prepared for this session today, I was looking online at what some of the hospitals are doing here. And tomorrow, one of the hospitals in Torrance is having a Medicare event because open enrollment is coming up, and the Medicare event, education event, is in Korean. So do your events in different languages, really recognize who your audience is, and build your organization around that. I think DiAn was saying, the expert is really the patient, and build it for them.
I don't want to stop anyone else commenting on that, but there's a couple other areas I want to make sure we have some time to touch on. And one of them is the topic, kind of the emerging topic on the role of visuals or art being a real powerful tool in terms of sharing information. And so I'm curious, maybe I can start with Michelle, though I know DiAn, you'll have thoughts on this too. How visuals reach an audience in ways that words don't, and how that can be a real effective tool when sharing science and health information, or is it another layer that maybe the public needs to then navigate or interpret? Like what side of that line do you fall on, and how can we make illustration be a really valuable tool in this conversation?
Yeah, so this is a really great question. So in LifeOmic, I work a lot on Lifeology courses. Sheila mentioned it very briefly at the beginning, but just kind of a rehash since I know it was like an hour ago. So Lifeology courses work on, they're basically like flashcard courses where you have about 180 characters, words to a card that is paired with an illustration. And then the courses are anywhere from like 20 to 30, 35 flashcards. So one is very difficult from a writing standpoint to be able to break down these very complex topics into just a little flashcard course. But then because we're doing that, we rely a lot on illustration to be able to kind of like supplement things and also make these very complex topics kind of more simplified. So the thing about written word is when we communicate, we rely a lot on nonverbal communication. That's the majority of the way that we communicate, which is why I use my hands a lot. I use my tone of voice a lot. It's just something about like being able to talk to someone and see them talking. That is just something ingrained into our brains to be like, oh, like I can trust this person or listen to them because of the way that they're talking and the way that they sound. And since we can't really do that with every single person and we can't rely on them, like we could do videos, but like what have good internet to be able to stream those videos. We could do it face to face, but what if they live 2 hours away from the nearest hospital or clinic? Then they're not going to come in to talk to you. So instead of just giving them this whole sheet of paper that's just a bunch of words on it that they might understand, it's pairing it with illustration is kind of one way we can bridge that gap of communication, where they can look at something, and if the illustration is done very well, then, and it's not just the quality of the illustration, but also how well does it pair with the words, which is something that we think a lot about with Lifeology. The process of making these courses includes storyboarding, where we put visual notes to try and like supplement what's going on in the words. And it's very challenging sometimes, even though I am an illustrator, to be like, this is the concept I would like for this word, especially for these very complex things. Like one of the courses we did just kind of to illustrate how this can help branch things over, was talking about a very specific thing in the immune system called the complementary system. It's just basically different methods that your immune system uses to fight off illnesses and bacteria. So there's like 3 or 4 different methods. And like, if I explain them, you'll probably just be like, cool, I don't remember any of that. But we have cute little illustrations where like the bacteria is like this little sea monster and it's being attacked by these little pirates, and the different methods that the pirates attack this sea monster relate to the different methods of the complementary system. So you can kind of see like, oh, this method is they're just looking at it and telling the other ships to come in and attack it, or this other method is they're literally just clinging to this thing and trying to just attack it that way. So it helps to bridge the gap, especially if we're worried about cultural differences, languages especially. So Russ says he speaks Spanish. I also speak Spanish. I guarantee it is a different type of Spanish because I learned in Uruguay and they speak Castellano there, not other types, and there's multiple dialects in Spanish. And even if you're speaking the same dialect, there are different words that are going to be very different from culture to culture, and even within different countries, they're going to be very different. And so if they have a very base understanding of English and they're reading these courses with the illustrations, it kind of also just helps them be able to pick up on what's going on, especially since they can't do this communication, like face-to-face communication with the nonverbal components. I think that answers the whole question. But yeah, I think it is a very effective way of conveying a lot of this information.
Well, and DiAn, I'm curious too, still in that vein of using the visual medium, what kind of process would an illustrator use to craft a story around a really complex health topic, right? I mean, that it seems like conveying that kind of information through illustrations can get almost as equally complex, if not more so, than writing it out in Word. So what's your thoughts on that, or what are your approaches?
I definitely think there are definitely complications. However, something about visuals gets rid of one really difficult problem that we have. It's so long as our medical information is being written by people who mostly speak standard American English. When we translate that into other languages, it doesn't matter because it's not going to be the right words, the words that that culture and community uses. Even let's pretend my grandma could get online and she just knew exactly how, and she looked up, she was trying to find out some information. She would put in something like stuck on commode with a sour stomach. That's not going to be in any search directories. Those are the words she uses. And unless they've used some really fancy SEO to make sure every single possible word is in there, it doesn't matter. They translate it, she's translating from her, and then we're translating from standard American medical. Actually, medical is not standard American English. The medical is something different. So by using visuals, first, hiring an illustrator can be really powerful because we all do whatever it is that we do because of how we think. It makes us good at what we're good at because of how we think. So first, how do we figure out ways to represent these concepts that are both mature enough so that it doesn't look, you don't want people to see it and feel like you're kind of making fun of what they're going through. I worked with another illustrator, my partner Gaius, who also made Lifeology content for a while, on a cancer course. And so, yeah, you want to draw something that is easy to understand, representative, the way Michelle was talking about, like with the pirates or something, but also mature, so that it isn't making light of something that's very complicated, very heavy, and very serious. And that really requires being able to deconstruct language on a level just all the way back to how would I explain this in a sincere yet educational way, and not to a child, that's not what you're looking for, but to a group of people who none of them speak the same language. How would I show this? I actually think often about the genius of the IKEA catalog, which I just recently learned is pronounced IKEA. But anyway, no words. They use not a single word in them. Like they don't produce 17 different language. No, it's all images. And being able to simplify something down to, oh, this character strikes me. How do you make sure the person identifies the character as themselves? So how do you make sure they say, oh, this is me. So I'm the person who's being attacked, and these are the things that my body are doing. So you have to think about it from that way. What are the universal archetypes and imagery that so many people, not every single person on earth, right? But we have things that have existed that we share across culture. So again, it comes back to cultural competency, being able to look at art and images that aren't from your own backyard and say, okay, you know what I always see is, for instance, the 7 general expressions. No matter where you go in the world, if you do something like this, they understand that you're happy, you're trying to be polite, you're trying to be friendly. So we start with something that simple, and then you create images based on that can cross cultures, cross language, yet still teach in a meaningful way. Because again, you also don't want it to come across as, but this is some kid's book, this is children's education, don't look at this. I feel like we have a lot of bias in America, especially, not everywhere, against comic and graphic images as like, oh, this is something that kids and teenagers look at. I don't need pictures, give me the words. We need pictures. A lot of our communication is just naturally out in the world. It's visual.
It's just visual. Yeah.
Yeah.
Mm-hmm. One thing I would add to that, I think it's a moment just to bring back the numeracy question, because graphics, I'm sure Michelle and DiAn will agree with this. Graphics are a great way to talk about numeracy. There's an example in the literature of a misunderstanding between English and Spanish. A doctor writes once times day, in the morning or whatever, and you're supposed to take 1 per day. You read it from the point of view of a Spanish speaker, it says once por día. Once, ONCE in Spanish is 11. So it looks like you're being asked to take 11 per day. Okay. And, there's just so many possibilities of a numeracy mistake or a numeracy clarification through maybe making a graph, making a picture of something that helps people understand a dosage, or, so numeracy and art will, are really helped in health literacy and health numeracy.
That's an excellent point. Thank you for bringing up the topic of numeracy again. Are there other elements to that you were wanting to highlight I think there was a question earlier on about the role of numeracy in managing diabetes and hypertension for folks. Curious what anyone's thoughts are about that more broadly.
Certainly one thing is, we talk about jargon, and one of the things that your doctor will tell you every time you go to a visit is they'll say, well, your A1C is at 7, your A1C is at 5.6. Now, what does that mean to me? Is that good? Is that bad? What is A1C, and why is it called A1C, right? And how does that relate to my overall sugar level? So understanding those numbers, and it's even worse when the doctor looks at your 2 pages of results, and they look at it and say, well, they all look good. There's nothing that's on the lab results that's out of the normal, but that doesn't tell you anything. Do you continue to do what you're doing? Is there an instruction there to improve, to walk more, to eat less sugar, to whatever it is? So we do need to delve, even for people that are in the healthcare industry, when they go to their doctor, just to get a comment about their lab reports that it's all great, well, we know it's not that great. But where do we have to improve?
I'm cognizant of the time, and there are 2 questions that came up in the chat that I'm hoping we can give just some brief initial answer to. One is an interesting question about what to do in situations in which something is forbidden or worrisome to an individual or to a community because of religious beliefs, and that we haven't really touched on that topic as much in the cultural competency discussion, but the role of religion and the example again that is brought up here is allowing a vaccine if it goes against beliefs about God's wishes or role. What do people think about the role of religion in health literacy?
Very complicated. I actually have an example of vaccine hesitancy applied and like how a certain organization handled this. So the Ronald McDonald Foundation, I don't know if a lot of people know this, but a lot of hospitals will have a Ronald McDonald area or house, and they basically provide housing and food and just basically care for families of pediatric patients, so patients who are children. And they had to, so these children are high risk, obviously, for COVID and for complications with COVID. So when the vaccine came out for COVID, the agency here in Utah had to discuss how they were going to handle vaccination status of the people that were going to be coming into the house. And if you don't know, Utah is very heavily religious in certain ways. And a lot of families were trying to claim religious exemption to avoid getting the vaccine so they could stay at the Ronald McDonald House while their child was receiving care, which is a problem. Just there's a lot of discussion about this. I try to be very sensitive, but basically the organization themselves had to discuss how they were going to handle these religious exemptions, and they basically talked with corporate and made a list of the specific religions where it is written within their religion that vaccines are like frowned upon or against the religion. And basically they asked every person who requested the vaccine exemption to stay at the house which religion they were a part of, which was a thing they could do because they're a private organization. And they basically made decisions based on that. So unfortunately, with the health literacy, it's kind of the double-edged sword, walking a very fine line of knowing, one, what your organization can and cannot do as either a private or public organization, and then having these discussions of how to approach different situations before they come up, which requires a lot of critical thinking, a lot of consultations, a lot of talking and understanding your demographic. And then unfortunately, we sometimes just have to accept that certain things are the way they are. But also just talking with people within those communities and kind of knowing how they how they approach things, why maybe they are hesitant towards these particular healthcare interventions like vaccine. And kind of just discussing, like trying to see if it's a lot of communication and understanding how people work. It's kind of the whole discussion that we've been talking about, how the healthcare provider is also the patient. Like we are also learning from our patients to try and see, okay, so why is this forbidden? So why, like how are different ways that we can approach this? It's such a complex topic. And I'm sure like other panelists have other things to say about it too, because it is so complex.
That may be an area where really being careful to be curious and open to the conversation and truly interested in the thought process of another person, comes in, it's just really important. I don't want to minimize that topic, but I also do want that this other person has brought up I think an important point that we haven't touched on too much. And again, I'm very aware of the time. So, but just to ask this, this is a question about, I think, the role of social media in conveying information. And the person's specific question is how to convince a decision maker that a channel such as social media could be set up appropriately for disease awareness, specifically if trying to communicate with teenagers on a healthcare topic, that could be a really useful tool, but in a way to engage and train the audience without having a sense that you're somehow diminishing it by using social media as an outlet. And so I think the question really is about the utility of social media, and wonder what you all think about that as a useful tool for communicating information.
I certainly think it can be useful. So many people use social media. I think one of the biggest points is to recognize whatever the population is that you engage them in whatever it is that you're trying to develop, whatever initiative you want to push forward, because they have to be a part of the conversation. They have to have a seat at the table. They have to, be a part of that process. No group is monolithic, so there are going to be some changes. There's going to be some nuance, but certainly talking with the community that you're trying to target, certainly they have to be a part of that process. And if it is something that's going to be helpful and valuable for them, then I certainly say go for it.
The only thing I'd like to add to that is, as far as convincing a decision maker of that, is there's research now. Social media is not new. Social media has been around a good 10, almost 15 years at this point, and there is peer-reviewed literature out there showing the efficacy of social media campaigns in distributing information in a meaningful way to different populations, stratified by age, stratified by SES, socioeconomic status, speaking of jargon. We can see all of that stuff. So especially if this decision maker is like a healthcare provider or somebody who understands the importance of peer-reviewed literature, that literature is out there. Go, Google Scholar, whatever your favorite is, and look up, the efficacy of social media campaigns and whatever it is, whatever your other word is. That is really important because it does exist. I've had to use it before. So
I just shared in the chat box some videos that you might find interesting that we promoted through social media for a rural clinic organization in Arizona. And we did this to combat vaccine myths and vaccine hesitancy. over the last year, and it was a very successful campaign. So you're welcome to use those videos. They're both in English and in Spanish, and I think you'll find them interesting. So the link to the YouTube channel is in the chat box.
Yes. Well, wow, wonderful. I think, unfortunately, that's all the time we have for this conversation today. So thank you so much, everyone, for joining us, and especially thank you to our panelists for your willingness to share your expertise. We hope to see all of you, panelists included, at a future Life event. To everyone, please just look for our upcoming opportunities to promote health literacy through our Health Literacy Month Course-a-thon, where you can use our Lifeology Builder to create a course around mental health for a chance to actually win a cool prize, a cool cash prize. More details at lifeomic.com/health literacy month, all with hyphens in it. And thank you so much to everyone once again. Have a great afternoon.